Noses are very different from one individual to another. They've been described a snub nose, a hawk nose, a Groman nose, a Greek nose, a celestial nose. But basically, they're due to structural differences in the nose, and often that's due from ethnic or ethnic reasons. Different ethnic types have different structural differences, such as a Asian nose, for example, has a little bit bulbous in the tip and maybe flat on the bridge. Aquiline nose or a Caucasian nose has very thin skin, which highlights a lot of the cartilage changes underneath. There are noses which are very flat, for example, again, Asian noses or Hispanic nose or African American noses. So there are structural differences in size and shape and different textural differences and thicknesses of the skin, which make the noses look very different. Well, the operation of rhinoplasty is performed under local anesthesia with IV sedation or general anesthesia. At our facility, we do the surgery at our own operating facility, which has all the bells and whistles as if the individual was going to have the surgery in the hospital. But we usually do it under IV sedation. This is done for patient preference. Most often, patients find it less threatening to have the surgery done in an office surgical facility where IV sedation is used. It's certainly less cost-effective. Patients are more comfortable in an environment where it's perhaps less threatening. The surgery is done by making incisions basically inside the nose and working underneath the skin. We're working on the cartilage and bone, and we're reshaping and recontouring and bringing together or widening different areas, taking away or adding. Cartilage grafts are an integral part of the operation in order to structurally enhance the nose so that it doesn't fall victim basically to the wound healing issues which we described earlier, which involve the distortion of the nose. Rhinoplasty is considered probably one of the most difficult operations in plastic surgery, and this is because it requires a high degree of technical proficiency, which is learned over many years of doing many cases. It probably requires maybe several hundred rhinoplasties so an individual feels just comfortable doing a primary rhinoplasty, which is probably one of the simpler cases to do. The wound heals basically by contraction, and we're operating in 3 dimensions, not only operating on a flat surface, but also on a third plane. And as these wound contracts from all the incisions which are made inside the nose, there's some distortion which can occur. And it has to be recognized in advance of the procedure that these factors do occur, and we have to anticipate them in advance of surgery and do certain maneuvers anticipating the way the wound's going to contract and heal. So there are very many factors that are involved in healing, and we don't necessarily have control over all of those factors, but we try to anticipate as many as we can at the time of surgery to minimize any distortion or any irregularities which may occur. Nasal surgery for functional purposes and for cosmetic purposes we prefer doing simultaneously at the same time of surgery. An individual may come in thinking that they want to have just a functional repair and then say, well, maybe I'll do the cosmetic procedure at a later date. We probably discourage this and ask the individual to postpone the surgery so that they can have both surgeries done at one time. Anytime we're operating on the nose, there are inherent scars that form inside the nose. It will result in delayed healing, also prolonged swelling, anytime an operation is done more than once. So we try to do everything at one time and make a home run, hopefully. Intravenous sedation has many advantages for the patient. Basically, it is safer. Basically, there's no problems with deep venous thrombosis. There's no problems with pulmonary embolus. There's usually less problems with postoperative nausea and vomiting. Bleeding is less. The inhalation anesthetics, which are given under general anesthesia, cause a vasodilatation of blood vessels, so there's typically more bleeding. The operation can be aborted at any time very quickly, unlike a general anesthesia, which requires an endotracheal tube put in someone's windpipe. And when patients are awoken from general anesthesia, typically they will cough and retch, sometimes buck, and that causes additional bleeding and swelling. So we prefer it if the patient is amenable to that. And what I say by amenable is like they understand that they do not have to be unconscious to undergo this operation. It's typically like a dentist surgery, where you would feel pressure but not pain. In other words, someone's drilling on your tooth, but you don't feel pain. There's a vibration, but not pain. We're specifically blocking pain receptors, not temperature receptors or vibratory receptors. So it's pain-free, basically, and the patient has a very quick recovery. They're able to go home. There's usually less swelling, there's less bruising, and basically it's very cost-effective. There's been a lot of controversy about open and closed rhinoplasty procedures that have been performed. My preference always is do a closed rhinoplasty, which will avoid an incision in the columella, which is between the nostril. The incisions in the nostril are made to provide exposure to the underlying cartilage and bone. However, with experience and having done thousands of rhinoplasties, you develop a proficiency and a comfort level where you can operate kind of upside down and backwards and know how to do this without any sacrifice of the result. Cartilage grafts are very important in the operation in order to control wound healing. We mentioned earlier that the wounds that are made by incisions in the nose contract, and when they contract, they distort. And when they distort, you're going to have an unfavorable result. The cartilage grafts provide resiliency and support and structure so that when contraction occurs, it avoids this and avoids the distortion. So you can hide these grafts. They're invisible grafts oftentimes, but they provide additional support. And the cartilage that we use for this are taken either from the nose itself or from the ear or from the rib, depending on how much is utilized. Large structural grafts, which require a dorsal elevation, for example, on the bridge of the nose, or the large grafts in the tip, for a congenital reason or traumatic reason, generally would use from the rib. Smaller grafts, which are cartilage, are used from the ear or the nose. And cartilage, unlike bone, doesn't have a tendency to resorb. So with these grafts that we place are there forever, and they're the patient's own tissue, so they're very less likely to undergo any type of infection or rejection. A secondary rhinoplasty is an operation on the nose, again, which has been operated on before or has had a problem with either nasal fracture or been injured in some way so that it's altered artificially, either by surgery or trauma. Like other operations, there are potential complications with rhinoplasty surgery. Revision surgery is probably the most common thing that occurs in about 5% of cases, which is 1 out of 20 cases, which means they're small irregularities which may be palpable or visible or asymmetries. This often can be done and revised quite easily. Infection is very unusual, but the palpable irregularities are something that usually can occur, but not very often. Surgery is quite predictable in most cases, and it's very satisfactory. In fact, it's probably one of the most common operations in plastic surgery, which speaks for itself that it is so successful. The recovery time for rhinoplastic surgery is several weeks. The operation involves tape and splinting the nose for about 1 to 2 weeks. Packing is usually an overnight. Sometimes we don't have any packing at all, and it usually is a small little Maricel sponge with a string attached, which is removed the next day. This provides some internal support, and external support is provided by an aluminum splint and some tape. But it's about 2 weeks that the tape and splint is on, but there will be some continued swelling, but the result can be noted at 2 weeks. You can clearly see a demonstrable difference between the preoperative and postoperative result, even at 2 weeks, but there'll be some continued swelling which will resolve over a period of several weeks even after that, and for people who've had a previous rhinoplasty, even several months. Well, as I indicated, requires a long period of training that's involved in plastic surgery specifically. Those individuals who've had special training in ear, nose, and throat surgery, such as myself, that's otolaryngology and head and neck surgery, are very qualified. And individuals who've also had an added experience and training in a residency in plastic surgery or have an added qualification. There are 2 board certifications for otolaryngology first and plastic surgery second. And in my case, I am board certified in 3 areas, basically, which is the facial plastic surgery, the plastic surgery itself, and head and neck surgery. So basically, the individuals who have really a broad experience in functional and cosmetic surgery would be best qualified to treat a nasal problem. Most rhinoplasty surgeries that I perform are done in our own specially designed and built outpatient operating facility, which is off my office. This facility was built by Methodist Hospital specifically for intravenous sedation purposes. The facility has all the bells and whistles if you were to have the surgery done in an operating room, such as a pulse oximeter, pneumatic compression devices for venous flow. Also, we have end-tidal CO2 monitors, EKG, all the resuscitative equipment that would be necessary in the event we had a problem and we're prepared for it. The facility is actually accredited by a national organization, the American Association for Accreditation for Ambulatory Surgery Facilities. In fact, I'm an inspector actually for facilities around the country, and so clearly our facility is really up to date and has every imaginable safety device that we can think of.